Well, good afternoon, everyone. Welcome to Shaftesbury Society. Once again on this Monday, coming to you live from Midtown Raleigh. I'm Donna Martinez. So glad you are along today because we're talking today about something that is central to every North Carolinian's life, and that is the issue of health insurance and medical care. The cost, the access. We all deal with it every single month when we have to pay some sort of insurance premium, or if you get that bill in the mail after you've had some sort of care. So as we all grapple with the situation of high costs needing access, it turns out that here in North Carolina, we have an archaic state law that unfortunately continues to block some of our access to affordable, convenient care. Now, today, we're going to be talking with the author of a new study of Certificate of Need laws in North Carolina. In fact, this is the study right here. It's hot off the presses, just newly released from the Locke Foundation. In fact, my colleague Brene is going to be posting a link to this in the comments section of the Locke Foundation Facebook page, so you can take a look at it yourself. We'll talk with the author of that study. We're also going to hear about how and why we should mitigate Khan's negative effects. We're going to be hearing from a radiologist and a medical director in the Greenville area about his firsthand experience with Certificate of Need, trying to better serve his patients. We're also going to be hearing from a leader in the health insurance industry, Blue Cross and Blue Shield of North Carolina. And we're going to be looking at the prospects for either reforming or entirely repealing this law in the General Assembly. Joining me today for this conversation, our panel of experts. Troy Page is the Director of Network Contracting and Strategic Development at Blue Cross and Blue Shield of North Carolina. Jordan Roberts is Government Affairs Associate, my colleague here at the John Locke Foundation. And Dr. Bruce Schroeder is Medical Director. He's a radiologist at Carolina Breast Imaging Specialist in the Greenville area. Gentlemen, welcome to Shaftesbury Society. So glad that you were along. We're also joined today by the author I mentioned, Dr. James Bailey. He is Assistant Professor of Economics at Providence College, and he is the author of this new study. So glad you all can be here today. Dr. Bailey, let's start with you. Give us a sense of what you found here in your study published by the Locke Foundation.
Great. Thanks so much. So first of all, thanks for inviting me. Glad I'm able to sort of appear virtually in the middle of a blizzard here in the Northeast. And thanks for everybody else coming out to listen today when there are so many other things you could be doing, like day trading GameStop stock or something like that.
Making money or losing money, right?
Yeah. So, a lot of people are making and losing money in healthcare too, partly as a result of how the system's designed, what particular regulations are in place. And one surprisingly important set of regulations that people might not have heard of before today is what are called these Certificate of Need laws. So these are laws that are in place in North Carolina and 34 other states that make it so that if you want to open a new healthcare facility or expand your healthcare facility in all sorts of ways, you need to get permission from this state board before you can do that. And it's not like a lot of state boards that are there to certify quality and make sure that the care is going to be up to snuff. Instead, what the state board is charged with evaluating is whether there's an economic necessity for the care that doctors want to provide, which is usually the kind of thing that's left to the market in most other situations, right? It's the provider themselves, the entrepreneur themselves, that we think of as usually getting to decide whether they think there's an economic need there, because if there's not, they're the ones who are going to tend to pay the consequences if they're wrong, and that's how the free market system normally works. But in healthcare, these Certificate of Need laws do play a major role in most states. They were generally put in place back in the 1960s and 70s when attempts at central planning were a little more common. Some states thought this was a good idea on their own. A lot of them were sort of pressured into it by the federal government, telling them that, hey, you need to start regulating hospitals, regulating healthcare in this way, or we're going to take away your Medicare funding. But in the 1980s, the federal government changed how they did Medicare in a way that meant that if these con laws ever made sense, back in the 1960s and 70s, they don't anymore, because Medicaid works in a different and somewhat more sensible way now. And so the federal government told states back in the 1980s, hey, if you want to repeal these laws, go ahead.
And
And
Dr. Bailey, if you could just briefly explain for folks as well, what was the rationale behind the original certificate of need law from the feds? What were they trying to
right,
do?
right. So the biggest goal was to reduce spending. They saw that spending in healthcare, we know that it's high today and increasing today, but back then it was increasing at a very rapid pace, largely because of this new Medicare program. And they thought, how can we slow down what's going on with spending? And they reached for this very crude sort of central planning type instrument of trying to slow down the growth of new facilities. Right. And so they thought, hey, if we just make it really hard to build new hospitals and get new healthcare equipment, then people won't be spending as much. That was the theory, right? Now, decades later, we've been able to see how it worked in practice, and especially now that a lot of states have repealed, right? We can compare, how did spending evolve in the states that repealed their laws to the states that didn't, and so we can see that the con laws, not only did they not meet their goals, if anything, they seem to have kind of done the opposite of what their goal was. Because when you make it hard to build or expand healthcare facilities, it makes it so that there's a lot less competition in the market, and so that these incumbent providers who are already there, right? If you realize that it's going to be really hard to come in and build a new hospital to compete with me, now I have a lot more room to raise my prices, which is what they seem to have done. And so, if anything, these laws do seem to have increased spending rather than decreased it, at the same time that they've made it harder to access healthcare because it's so much harder to build or expand healthcare facilities.
Is that fair to
So,
say that's why a number of states actually said, this isn't working, and so let's go ahead and repeal this?
right, exactly, right. I think partly, partly some felt that the feds forced it on them, and they just took the first opportunity to get rid of it, and then partly just seeing, hey, how did this work? We sort of had, we're forced to try it for a few years. Didn't seem to work so well, and so yeah, time to repeal. So yeah, 15 states have done that, mostly in the West. It's less of a blue state versus red state thing than you might think. California, in fact, is the largest state that has repealed these laws. On the East Coast, you mostly have Pennsylvania repealed in 96, New Hampshire in 2016, and then Florida did a major reform, an almost complete repeal just last year. So yeah, just going over a few more of the findings. So I did a few things with this study. I did sort of some original research myself, looking at the data of how things have played out in different states that repealed their con laws versus didn't repeal their con laws. But I also surveyed the academic literature that's been out there, because these laws have been around for so long, a lot of academics have taken an interest in trying to figure out what happened. And so, I tried to read everything that's been written about how these laws affect the number of facilities that are opening, and what's going on with spending, access to healthcare, and quality of healthcare. So some of the published academic literature out there has found, for instance, that states with con laws, like North Carolina, compared to states that don't have them, have 13% fewer hospital beds, 26% fewer hospitals offering MRI or CT scans, 30% fewer hospitals per capita, just fewer hospitals, 14% fewer ambulatory surgery centers, places outside of hospitals that are able to perform some surgeries, 49% fewer neonatal intensive care beds for newborn infants, premature babies, and 42% fewer substance abuse treatment centers. And so these are just some of the ways, right, where when you make it hard and expensive to build a new facility, kind of naturally you'd expect to get fewer facilities. And I realized I might not have, said some of the ways that this process makes it harder is, and we'll, I think hear from somebody who's actually been through it before, Dr. Schrader, but there are sort of a few barriers to starting a new hospital that go up when you have this con law, right? So first, you can't just build or expand. You need to submit this application and wait. So there's going to be a time cost to that, where you're going to add at least a few months to the time it takes to build anything, which in times like these can be a very important few months when hospitals are at capacity. It's going to cost money, right? So the state charges people several $1,000s to apply for these. And that's on top of whatever they're going to spend themselves preparing the application in terms of their employees' time or paying consultants to do some of this work. So it's going to cost you time, it's going to cost you money. And after all that, the state might just say, no, we don't think your new hospital is necessary, rejected. Or we don't think you really need this new MRI machine in your clinic, rejected, right? And so that's part of why you're going to see fewer facilities, right? So some people will want to build a facility or expand a facility and actually just be rejected. And the state says, no, you're a doctor. You might think you need this, but I, a state bureaucrat, I'm telling you, you don't.
And
then
that's an interesting point. How would the state know that better than a doctor or a group of doctors or the hospital administrators who are on the ground in their community? How would the state know that?
Yeah, that's a good question. I would think they don't. I don't know what exact criteria they're trying to use to approximate it, but yes.
But for whatever reason, they've decided that this is the way it works. So the state's going to determine it. It's not going to be the people on the ground.
Right. Right. So sometimes they'll actually reject people, and some facilities would just be dissuaded because, especially if it's a relatively minor improvement they want to make to their facility, they might think that the time and money cost of going through the application process wouldn't be worth it, even if they would get accepted. So I think these are some of the reasons why you see fewer facilities available in the con states. So I was able to look at the academic literature and figure out a lot of what had already been written, but I did notice that there were a few things that just nobody seems to have written about. So I've been writing about this stuff a few years, and had found a few things like that. But one thing that some people at the Locke Foundation and the Civitas pointed out is that there's really been nothing written on how this is affecting mental health care, right? And substance use treatment. So that was something I tried to look into. So there was one previous study that did find that you get a lot fewer substance use treatment facilities. And then I tried to look into what's happening to the forms of payment that they accept, because there's one area where a lot of them don't take insurance. You see lots of cash-only facilities. And I was able to tell that those were a bit more common in the con states, that substance use treatment facilities were less likely to accept both private insurance and Medicaid. And likewise, when I looked into psychiatric hospitals, first of all, you see a lot fewer of them in the con states, about 20% fewer. And then they're also less likely to accept Medicare as a form of insurance.
And you actually found in your study, as it relates to psychiatric hospitals, that North Carolina could expect to add 3 more of them, increasing our capacity for folks who have that particular need if we did not have a certificate of need law.
Right. So there are 15 now, and typically, you see about 20% more in a state without con. So that is, what I would expect to see if North Carolina did repeal con, either overall or just for those kind of facilities in particular.
So that's where we get to the issue of trying to explain that with a certificate of need law, that it really does create a barrier to access. And particularly now, as we're going through the COVID-19 pandemic, we're reading and hearing so many stories about people for all sorts of reasons. Maybe it's because they can't work due to the shutdowns of their industry, or maybe it's because they can't cope with trying to educate their kids at home and also work, needing all sorts of help, counseling services, mental health services. And one has to wonder how many more people would have access to that type of care that they desperately need right now during this pandemic if it weren't for a barrier like this permission slip.
Yep. I think policy has been a big barrier there in a couple ways. So, one that does seem to have been changing a lot with COVID is allowing access to telemedicine. So, partly because of the epidemic and rule changes with Medicare, we are seeing a lot more of that, which I think people seem to particularly appreciate with mental health care, being able to talk to psychologists or psychiatrists. But certificate of need is another big barrier there in many states. And we have seen a lot of temporary waivers because of COVID, where a lot of states realize hey, weeks matter now, months matter. It's now sort of even crazier than usual to be making hospitals spend so much time jumping through these hoops to expand if they want to expand. And so you've seen many states waive certain requirements for during the last year. North Carolina has opened things up a little bit, but much less than some other states. So as I understand it, they basically added an extra application that you can do to make certain temporary changes that might be a little bit easier than the normal permanent application. But it's not like some other states where they just opened things up entirely and said, hey, you don't need to apply at all, right? If you need to add beds for, say, COVID patients in an ICU, just do it. Don't wait for months to tell us when your intensive care is full and you need more beds to help people now.
And that's interesting because that's an acknowledgement that the people on the ground in the community know what the need is right there and can make that decision based on real circumstances. Yes, we need more beds. No, we don't. That's so interesting and sad in many ways that it takes a pandemic for us to understand that and to be put in the position of saying, okay, let's let the folks on the ground actually make the decision. Well, Dr. Bailey, it's really fascinating results that you have presented here. And again, his new study published by the Locke Foundation is this right here. You can find it online at johnlocke.org, or if you're watching us on Facebook, I believe that, yes, we've posted the link there in the comments section, so you can take a look at all of the details there. So that's where we are in North Carolina. We do indeed still have certificate of need laws in this state, even though other states have already repealed their laws. Let's bring back here for our conversation, if we can, Troy Page with Blue Cross and Blue Shield of North Carolina, Jordan Roberts from the John Locke Foundation, and Dr. Bruce Schroeder with Carolina Breast Imaging Specialists. Troy, let's go to you first. You are with, of course, the major insurance organization. Give us a sense of the Blue Cross Blue Shield view of certificate of need. How does it affect what you do and your ability to serve North Carolina?
Right. So historically, and I've been at Blue Cross North Carolina for 25 years at this point, so I've seen a little bit of that history. We have been neutral on certificate of need issues. I'm sure there were political reasons, I'm sure, and definitely provider relationship reasons. But as I'm sure you won't be surprised to hear, over the years, we have seen big changes in terms of the affordability or lack thereof of healthcare. And some of the concerns that we've had around certificate of need are starting to, I think, be outweighed by concerns around ongoing affordability and the hope that increased competition can drive costs down and keep quality where it needs to be. Generally speaking, we're, as a health insurer and payer, we're looking for three components to our offerings to our customers. We're looking for good quality, we're looking for low cost and affordability, and we're looking for access. And it's getting tougher. I mean, I think everyone has seen the rising cost of healthcare. The latest statistics I've seen show that the costs are rising about on par with college costs, and both of those are way outstripping wage growth. So long story short, yes, we have, I think, come around to that it's of value to take a look at the certificate of need laws and see whether a change to those is appropriate. And from our perspective, certainly the lower cost sites of care that represent a lower cost, but still a clinically appropriate site of care from a hospital, that's an area that is ripe from our perspective for certificate of need law repeal.
Well, Troy, it's interesting because your description of what you are looking for, greater access, a downward pressure on those costs. I mean, that's what every North Carolinian is looking for as well. Everybody wants to be able to when they need a particular service or a doctor or a nurse, that they can get that access and pay what we would define as a reasonable cost for the care, or our insurance to cover the care. So that's really interesting that I think those two views, the views of the average person and the views of Blue Cross Blue Shield of North Carolina, really do seem to mesh there. Now, of course, what happens with care? Well, that's where we get to the issue of the people who are actually on the ground providing care. Dr. Schroeder, you are in Greenville and you are with Carolina Breast Imaging Specialists. Now, it's interesting because you have been providing a service first without a certificate of need, and then you applied for one for a particular reason, and you received it. Tell us your story, Dr. Schroeder.
Mute. Hey, good morning. Yeah, I think I have a unique perspective here. Not too many radiologists are going to be talking about CON and its merits or lack thereof. So a little bit of history. I was part of a general radiology group that had all of the modalities for a long time, for about 17 years in Greenville. We had grandfathered facilities that didn't need CON because they were in existence before the laws went into place, I think in the 70s or whenever it was. And then we also competed for CONs for MRIs and things like that. And I was part of that process, and it was quite a process with appeals and settlements and all kinds of things that just made everything more difficult and limited our ability to gain equipment to provide care. Of course, once you have the CON, then you're one of the haves and not one of the have-nots. And then you want it, and you want to keep it, and you want to keep CON laws alive because you have it and you don't want competition. But this was eye-opening to me when I went from being a have to a have-not. So I left that practice about 7 years ago to start my own breast imaging practice. And I'm a specialist, and that's all we do. We're all specially trained breast imagers, and we thought there was a need for having this. There are very few in North Carolina. In fact, there are none that are owned by anybody in North Carolina. We're the only one. But we thought there was a need locally, and I thought we could do better for the patients, the staff, the doctors, everybody, and the community, of course, by providing this service. So what I learned very quickly is that the CON laws are just very, very restrictive for anybody trying to do this. The law that would apply to me is called the Diagnostic Center. There's many subsections in the CON law, but Diagnostic Center is the one that I would fall under because I was going to have diagnostic equipment. And that law says you cannot have more than $500,000 of total equipment. Otherwise, you need a CON. It doesn't say you can't have it. It says you have to then go through the process, which could take a very long time, maybe a year or more. It's very expensive. I mean, I spent tens of thousands of dollars for an attorney just to prove I didn't need to get a CON.
Oh, my
That's
word.
called the no review process. So the attorney is the one that went through all my expenses and all the numbers. And, you know, we had to make a very difficult decision. I wanted this to be a shiny new practice, a boutique practice for my patients. And I was going to buy the latest and greatest equipment. And that wouldn't add costs because I get paid the same from Blue Cross, Medicare, whoever, whether I have new equipment or old equipment. But I was forced to buy refurbed equipment just to get in under these thresholds. And spent tens of thousands of dollars just putting together this list of costs. And I mean construction costs and power and computers and all the things that go into providing the service by these pieces of equipment, just to write a letter to the state that says, we don't think CON applies. And eventually they wrote back and said, okay, yeah, it doesn't. So that was a delay and a cost. So we were able to open kind of on a limited basis with under $500,000 of equipment. Now, I wasn't there in the 70s and 80s when these things got put together, and the numbers, $500,000, maybe made sense. And I'm sure And I would say to this day that nobody is trying to restrict breast cancer screening services with a certificate of need. It was designed for high dollar imaging equipment. At the time, a CAT scanner was probably $1 million and a mammo machine was $40,000. Now you can actually get a CAT scanner for under $250,000, and some of the mammogram machines are $400,000. Things have changed. And the people who I've seen in our community who've purchased CT scanners under the CON have bought some of the cheapest, poorly made pieces of equipment just to get under the cap. Whereas had there not been a cap, they might have actually spent the money on a high functioning piece of equipment. So it really does have a counterintuitive effect on what it was trying to accomplish. And of course, those numbers, $500,000 in 1975 bought whatever it bought. It hasn't scaled at all. It hasn't changed a penny. So we functioned. We opened the practice in 2013, and we kind of got along growing our practice in the first year. And then in 2014, 3D Mammo came out. It was out since 2011, but the one I wanted came out in 2014. In order for me to then upgrade my equipment to give my patients the latest and greatest, it was going to put me over the $500,000 threshold. And at that point, I had no choice but to either not do it, which is wrong for everybody, or go through the CON process. And I was nauseous thinking of the process. Imagine it cost me tens of thousands of dollars in legal fees to not need a CON. God knows what it was going to cost me to actually go through the process. But I didn't have that. I had to spend the money on mammo equipment. I really wanted to put the money into patient care, not into checking boxes and writing papers. So I will tell you, my wife and myself did the worst term paper it was very well done, the hardest term paper we've ever done. And we spent every night, weekend and day for months putting this together ourselves. We did not use a lawyer because I couldn't afford it at the time. Things like we had to get the bus schedules to make sure that the patients could have public transportation access. We were asked to guarantee that when we get our piece of equipment, that all the pieces of similar equipment in the community, and I'm talking about the ones I don't own, would be used at 80% capacity even after we got ours. I don't know what my competitors do. I don't have access to that. So all of these arcane, requirements made it very, very difficult. But we put this thing together and then, kind of submit and pray. And the process takes 90 days for them to prove. And then there's 30 days for your competitors to protest and appeal.
That's an interesting piece. Explain that.
Well, even if they give you this, I guess it's preliminary approval, or they have it, well, they say it's conforming, meaning we've checked all the boxes and we haven't broken any rules, and they have no way to measure whether what we said is accurate. We did our best to estimate 2 years down the line what our volumes would be. And then they put it out there. It's all public record. Every penny I paid for my equipment is public record. And then your competitors, or whoever feels that they're a party to this or they are affected by this, can appeal it, and then could drag you down for God knows how many months. And I've seen, not in this case, but I've seen in other cases where that appeal was just a money grab, because to make the appeal go away, you pay off the guy who appealed it, the competing practice. You give them some money, now you shared in everything, and it moves on. They withdraw the appeal, and that's all apparently legal.
Is that what you actually experienced in your?
Not in my case, but in my past life. Not in the breast, not in my CON, but I've seen it happen in other CONs where the appeal was settled with a cash payment to a competitor.
Oh my word!
And obviously the lawyers are making a lot of money doing all this. Again, now, so I went through the process and I got a CON, and now I'm one of the haves, which is nice to have, but wrong is wrong. And, I should be sitting back and saying, well, now I want to keep the CON, but it's hypocritical. At a minimum, we need to make sure it is accomplishing what it was intended. It was not intended to stop breast cancer screening access. There's no way. So either you carve out some of these primary care functions and preventative medicine functions completely, or you change the caps. I mean, $500,000 for all the equipment and construction in any facility is nearly impossible, and harder now than it was even 7 years ago because the equipment got more expensive because it's better technology.
Dr. Schroeder, it's quite a story. I think it's important for people to understand. This is the reality of what I'm sure, no doubt, as you referred to, the intent, the original intent was a good one. It was to try to bring down costs, and try to give people access to care. But you used a phrase a couple of minutes ago that really sticks out in my mind. You said things have changed. And Jordan Roberts, as I listened to Dr. Schroeder's story, I kind of wonder if maybe we are at a point where we simply need to help lawmakers and policymakers understand that things have definitely changed and it's time for a reset in North Carolina.
Yeah, absolutely. And so, as Dr. Bailey said, I mean, these laws were put into place back in the 60s and 70s, and a lot of states repealed them at the time. And since then, groups like the John Locke Foundation, the Federal Trade Commission, and the Department of Justice, just to name a few, have been one of the ones banging the drum saying these laws don't accomplish their need, or they don't accomplish their goal of keeping healthcare costs down. We know that healthcare inflation rises higher than normal inflation, and we've continued to see that over and over again. And so, I think the panelists on this discussion really illustrate the need for change. I mean, we have Dr. Bailey's new paper that lays out the data that shows healthcare costs are higher in states with certificate of need laws, and there's less supply, which is part of the goal is to keep supply correct in a given area. Then we have Dr. Schroeder, who's saying, on the ground, I am having trouble providing care to patients because of my compliance with these laws and dealing with these laws. And then on the insurance side, we have Troy that's telling us that when Blue Cross is looking at building networks and bringing on new providers, that the prices are just can be too high sometimes. And so what does this all mean, especially in light of COVID, that we really need to focus on healthcare supply here in North Carolina. We do have a good bit of supply, but it's very maldistributed, and that's one of the problems that the certificate of need law doesn't allow us to fix in North Carolina, is that folks who want to open up in underserved areas, just like Dr. Schroeder, may not have the financial means to open up a new practice. And so, when I think about lawmakers coming back to session this year, thinking about, well, we just went through this pandemic where we talked about hospital bed shortages and access to care shortages all over the state. How can we fix this? Well, I mean, look at the evidence laid out on this panel that, it's affecting people across the spectrum. And it's not just the John Locke Foundation. It is, major entities across the United States that have been saying these laws do not accomplish their intended goals. And, if we really care about patients, we can't forget the patients and the providers in this scenario, because that's who it's affecting most, especially folks in lower income areas that, may need imaging services or may need to get a procedure done in an outpatient center that might be more affordable, but they just don't have that access. So I think it's, it really just illustrates the problem here. And I think it is time for change, especially in light of COVID. So I hope, as we move forward into this session, the North Carolina Senate typically in the past has been much more partial to con repeal or con reform. The House has been a little bit more resistant, but like I said, it's a new year. We've just been through a terrible pandemic. We're still going through a terrible pandemic. And so, when we look at all the evidence, we look at these firsthand accounts from folks that are involved in the process, it is time for change. And I really hope that, we can, get some work done, get some reform done at the General Assembly this session.
Troy, as you listen to Dr. Schroeder's account of what it was like to go through this, what does that help inform the Blue Cross position and view of this when you hear directly from a provider who's saying, hey, I had to go through all this. Meantime, I'm trying to serve my patients.
Yes. I mean, I think it's definitely an eye opener. If there's any wonder why, there's not a lot of access and competition out there, that's a case study for it, right? It's a tough barrier to entry. Yeah, I totally agree.
And Jordan brought up something. He brought up something interesting, I thought, Troy. He made reference to maybe parts of the state where it's a little bit harder for folks to access care, maybe folks who are living in a more rural area or a secluded area of the state, maybe a corner or a pocket of the state where they're not near a big facility or access very easily to doctors, nurses, and other care. So what's your challenge at Blue Cross as you try to make sure that you're serving the entire state, knowing you've got to find providers all over the place and knowing that there's something in place that is really a barrier to that?
Yeah, that's true. North Carolina is fairly unique in terms of the rural areas that we have in juxtaposition to the urban areas. We do have areas that really are underserved from a provider perspective, and we also have quite a bit of provider consolidation in North Carolina, and I think that plays into this as well. Out of the roughly 110 hospitals we have in North Carolina, we were looking yesterday. We have around 20 that are independent at this point, and not part of a consolidated healthcare system. So, of those 20, 7 are in rural areas. So, we've got, even in the rural areas, the hospitals are hospital systems as opposed to independents. So yeah, opening up for quite a bit of competition would be helpful. Encouraging folks to open up services in underserved areas absolutely would be good. I think from the Blue Cross perspective, and I know this is probably outside of the scope of this discussion, I think when it comes to opening up or repealing the certificate of need laws for the higher cost sites of service, the top level services like psychiatric hospitals, like inpatient acute care hospitals, we would want some care taken there to make sure that we're also looking at interrelated laws and regulations that can have unintended consequences. In North Carolina, for example, there's a current regulation, law, legal interpretation, or regulatory interpretation rather, that if you've got an out-of-network emergency department and an emergency occurs, if they're out of network, if we can't work out and negotiate a rate with that provider, we have to pay charges, full charges. So that can be a situation, for example, where, if you opened it wide open and freestanding emergency departments started popping up everywhere, which are very convenient sometimes for people to go to, you could have a situation where that drives healthcare costs up, not down. So I don't have the answers, but just saying that as we're looking at repealing certificate of need for higher cost sites of care, let's look at all the interrelated laws and regulations that are going to have unintended consequences there, and hopefully have those part of the mix as well.
Yeah, I would say that I have a similar perspective. So, CON is there because of the theory of if you build it, they will come. If I put up an MRI machine, I'm going to figure out how to fill it up. But if you look at our perspective in radiology, anyway, we don't have the ability to generate referrals. People have to send us patients. We barely even set our prices because you pretty much tell us what you're going to pay. Medicare certainly says what they're going to pay regardless. So CON is having an unintended good effect, but it doesn't mean CON is a good law. It means we need to, like Troy just said, when you address CON and repeal it, you have to make sure that you address the things it's actually doing well on the other side. And one of those, radiology will agree with me for a change rather than try to kill me, is self-referral. So one of the reasons CON has some value is because it limits every provider out there from putting up an imaging center or MRI machine and filling it up with his own patients. So CON does have an effect to that in that respect, but I don't think that means CON is good. I think it means that the self-referral laws are weak. So those need to be addressed probably hand in hand with pulling out some of the CON protections, because it does have that unintended good effect.
You know, Jordan, as I was looking back over some of the details on certificate of need laws in North Carolina, I took a look at a piece, actually, Jordan, that you wrote last year. And for folks who are watching us and for my colleagues, this is the Policy Solutions 2020 document that you can find online at johnlocke.org. And go to the healthcare section. There is a list here, Jordan, that you compiled, you put together for this, services that require a certificate of need in North Carolina. And folks, it is long. There are, I would say, at least 18 to 20, maybe more than 20 different categories of services. Jordan, give us a little bit of an overview, if you would, on some of the things that are covered by the laws here, because people might think, oh, we're just talking about hospital beds, or oh, we're just talking about MRIs. This really doesn't affect a whole lot of things. Actually, a lot of things are affected.
That's right. And, North Carolina is one of the most restrictive states in the Southeast and the whole country when it comes to the number of services that are regulated. And, like you said, it's not just hospitals. We're talking about, hospital beds, the number a hospital can have, ambulatory surgery centers, a lot of medical imaging equipment, such as PET scanners, CT scanners, things like that. And then also another big one is dialysis centers are regulated under the certificate of need law too. So, we have all of these things that are covered that, deal with that kind of care. But then we also have, intermediate care facilities for individuals with intellectual disabilities, substance abuse centers. So it covers all these broad ranges, as Dr. Bailey pointed out in his study, that, we have one of the most restrictive, some of the highest number of facilities and procedures covered by certificate of need law. So that's why, we're really saying we need to look at, what is necessary to be covered under this law. We don't think anything, because, we agree with some of the sentiment that's been said, that the private market, the folks on the ground, should be the ones to say, if I want to set up shop here, then I deal with those consequences of, how many patients I can get. But, it's just become the status quo in North Carolina that all of these services are regulated. And as Dr. Schroeder said, it's really become sort of a corrupt system that's abused by a lot of folks that, are either trying to settle with people that they're appealing their certificate of need applications, or sometimes entities will receive a certificate of need and never build anything. They just hold it to keep their competition out. So not only is it raising healthcare prices for a lot of folks and, limiting the amount of supply, but the system is also being abused now. So it's sort of a double whammy. And so that's why, we just really think that it's time for us to, all the stakeholders in North Carolina to come together and say, we all have concerns about healthcare costs. We all have concerns about healthcare access. Everyone's got a different interest in this system in some way, but, how can we make this work to get the most benefit to North Carolina providers, the insurers that are operating in the market, and of course, the patients at the end of the day.
And to your point, Jordan, we have a comment from, let's see, I just lost it here, but we had a comment in the Facebook, on the Facebook page, essentially saying that in Northern California, that this person had read that there were some people who, through the certificate of need process, had actually were operating a de facto monopoly at one point. And so it's hard to believe that, but it's accurate apparently, that someone can actually apply for or get the certificate of need, but then not do anything. It's simply meant to be a protection against someone else coming in. And Troy, it just strikes me that with all of these different categories of services that are subjected to certificate of need in North Carolina, that this has to really permeate your business and your industry, because it's not as if it's only 2, 3, 4 specialty areas that you all would be providing insurance for. It's unlikely that there would be any North Carolinian, it seems, looking at this list, who would be unaffected by having their access limited or their ability to see a provider at an affordable cost. It's just unlikely that they would not be affected by this. And that, of course, gets to you and how much things cost and our ability to afford insurance.
I agree. And in fact, some changes industry-wide, but and specifically in North Carolina, are sort of really calling that into stark relief because of the affordability issues that we're having for our customers. More and more, we and other payers are creating narrow network products. So think of insurance products centered around a particular healthcare system or a particular group of providers. It doesn't include everyone, it includes a smaller subset in order to get the best pricing possible, more volume, better pricing. Yeah, competition, increased competition would give us the ability to go bigger, I guess, with those narrow networks, have more of those because of the limitations we have currently on adequacy requirements, which are appropriate at a high level. You need to have access for your members. It's difficult to create a narrow network with appropriate access if the system that you're trying to partner with is not able to get for example, a certificate of need to open up an ambulatory surgery center that you may need to round out that network. I agree. I think it kind of touches every member, and more as we're doing narrow network products.
Now, it's interesting that I think it was Dr. Bailey who mentioned during his presentation that we've seen during COVID-19 that many states, including North Carolina, but he said North Carolina to a lesser degree, have actually lifted some of those requirements because we're in an emergency situation. So that gets me to the issue of moving forward. And Raymond here commenting on our Facebook page saying, how do we make effective change? We're aware of the problem. The old remedies don't seem to work. Let's talk a little bit about what can work going forward. We do have a few things where we can look at a service and know that it has been moved out from under a certificate of need. We can kind of analyze how that has worked or not worked. Jordan, it seems like we've got a pretty good building blocks on a few things. Help us understand that.
Yeah, so like Dr. Bailey said, I mean, Florida just recently repealed their certificate of need laws for almost everything. We've had a couple of other states that have done this in recent years, but I think the biggest thing that we need to realize is that a lot of what we're talking about here, the groups that are in major support of certificate of need laws, particularly the large hospital groups, with the case that they have laws that they have to see patients and keep their doors open, they're worried about an uneven playing field. But what I would argue here is that in North Carolina, if we were to open up the certificate of need laws, like that we're advocating here for, that there would be enough supply still, and the hospitals would still be able to operate at the current rate levels. And I think this is abundantly clear in other states that hospitals can operate. We see similar levels of charity care being provided in states that don't have certificate of need laws and do have certificate of need laws. And I think the argument that a legislator might hear that a hospital may close in their district is a really compelling one. But I think when we look at the evidence and we look at the lack of supply, to just stick with the status quo, I don't think is going to be acceptable any longer, because we know we have these access issues. We know we have these supply issues. And what we're kind of saying to patients is, well, you got to deal with the system the way it is, because, there may be some unintended consequences. But for a lot of those folks, that means no care. That means driving hours for care. So, I just think, at the end of the day, what we've been having this discussion at the General Assembly for a number of years. At the federal level, they've already made up their minds that they think that these laws should be pulled back. So, I think we can look at, try to mitigate the unintended consequences like was discussed before. But at the end of the day, we need to, think about the patients in this regard and say that, we're going to actually do something that may help you, as opposed to just leaving you with no supply, no care, high cost care. That's been the status quo for quite some time.
And Dr. Schroeder, really listening to your story, that's exactly what you were trying to do. You're trying to better serve your patients. Help us understand how a certificate of need, how this new equipment, et cetera, has helped you better care for your patients.
Well, again, specifically, we went through the CON process when 3D mammo became obvious that that was going to be the standard of care. And for us to provide breast cancer screening without 3D mammo would have been substandard, and I don't want to even think about what I would have had to do, because I would be faced with the choice of closing the practice, which obviously limits access and competition, or keeping the practice open and providing what I know to be second-rate care. I won't do it. I mean,
Now, you're actually dealing with trying to detect breast cancer.
that's what we do.
That's what you do.
Only exists for breast cancer.
For the women who are watching us, most women have probably heard the phrase dense breast tissue from a doctor that they have seen. And that requires the ability to actually screen tighter, to have a better picture to detect that cancer that might be there.
In fact, since we got the CON, we were able to add new equipment for whole breast screening ultrasound, which is a supplement to mammo and 3D mammo to find cancer in dense breasted women. Without CON, we would not have been able to do that. Those machines are $150,000 a piece, and we have one in each of our facilities. So, I mean, just being able to look at what do I need, and I'm willing to spend the money to provide the technology and the equipment that my patients need. That's my decision. I might make money, I might lose money. It might take years to get the money back, but that's my decision. To be able to do that without saying, am I allowed by some arbitrary rule, it has been freeing. It's been liberating for me to be able to actually run the practice the way I think I should run the practice. So yeah, we wouldn't, without CON, we would either not be here or not be doing a good job. And I think we are doing a good job.
Now, hasn't there been instances, Jordan and Dr. Bailey, I think both of you could probably speak to this, where the certificate of need requirement has been removed from a particular area or specialty in North Carolina, and for one reason or another, and so they're operating in more of a free market environment. And tell us about those areas and an example of where it's been done and it's worked.
Yeah, so I believe it was in 2005 that North Carolina did do a little bit of reform, allowing gastroenterologists to perform colonoscopy in their own endoscopy units, which basically just allows them to do more procedures inside their own facility rather than outsourcing that to the hospital. And, the results were great. The utilization of those services went up, and what we've seen in some of the research is that, by allowing those procedures to happen inside that office rather than out in a hospital, there's major savings for Medicare and, I'm sure for private insurers too. So what we've seen is when, you allow the market to work, there's going to be some corrections, but there's also going to be a lot more, proper distribution of resources, of supply and demand there. So we have seen some evidence of it working here in North Carolina, and that's why I think we should continue.
And Troy, I would suspect that in your company, in your industry, you have probably watched that pretty closely to see how that has worked. Give us your point of view when it comes to what North Carolina has already done and how that might impact a lawmaker's decision to go forward.
Yeah, the example just given is a good example. Anytime we can make available, and I'm not a clinical person, so I can't speak to the clinical appropriateness, but others have and have determined that office-based setting was clinically appropriate. Anytime we can make lower cost, clinically appropriate sites of service available, that's good across the board. So sometimes people will think, well, okay, now the insurance company is going to save money. All of that directly impacts premiums. So it's not only cheaper at the point of sale, so to speak, it's also just cheaper overall for the premiums and the cost to everyone to buy insurance. So absolutely, we haven't seen much movement in certificate of need laws, but definitely where lower cost sites of care open up and become available, that is a good thing across the board for North Carolina.
Dr. Schroeder, as folks at the General Assembly specifically start taking a look at at this issue and weighing the pros and cons and what might be appropriate, what are one or two of the things that you would like them to consider and to understand so that they can make a sound, fully informed decision about certificate of need in North Carolina?
I will leave it up to the rest of everybody here to decide whether complete repeal is appropriate, but focusing on specifically the place that affects me and my ability to deliver care in the diagnostic center provision. Look at whether it makes sense at all and what you're trying to accomplish, who you're trying to keep out of business. Number two is if you do keep it, you have to adjust the numbers. I mean, even in general X-ray, X-ray equipment 30 years ago wasn't digital. It had darkrooms, had all kinds. It was a bad way to do it. It was the best way at the time. Everything's gone digital. Everything's more expensive. Just keeping up with inflation would double that amount of allocation from $500,000 worth of equipment to $1 million. And then, selfishly, actually not selfishly, because I have a CON, I don't need another one. But what's right is to maybe carve out things that have been innocent bystanders in this, like breast screening. I mean, it's long. Appointment times for screening mammo were going up. We're still playing catch up with COVID, and people are out, months and months sometimes. To limit access to something where utilization doesn't cost money, it saves money. We think utilization of breast cancer screening services and mammo actually saves money in the long run. That's why it's a covered service. That's why we recommend everybody getting it every year. So limiting access to a preventative service like that makes no sense, regardless of the dollar amount. You just shouldn't do it. So I would say repeal diagnostic center, raise the caps if you can't do that, and potentially carve out specific things that make sense, like breast cancer screening.
Dr. Bailey, your study gives folks a really good starting point to take a look at the background and some of the academic research and some of your original research as it relates to substance abuse and also mental health treatment facilities. So Dr. Bailey, what is it that you would like people to understand that would be a building block for moving forward in North Carolina?
Yeah, the first thing, which I hope we've accomplished today, is just to know that these laws exist. I think people not knowing about it is the biggest reason they've been able to persist, because I think for the most part, the only people who've known about this system are the ones who benefit from it, which tends to be, the big incumbent hospitals and the people, the providers who already have one of these certificate of needs. And nobody else knows about it, right? But everybody else is the one who's paying for this in the form of, higher spending and longer travel times to care, less access to care than we'd otherwise be getting. So, sometimes this is called the logic of dispersed costs and concentrated benefits, right? So the hospitals who benefit from this, they know about it. They're paying attention to what's happening with the laws and the hearings, right? They have lawyers working on this. But the rest of us who, just have to spend, 3% more every year as a result of this on care, or who have to drive a little bit further to find a facility, right? We probably don't even know why it is that we have to spend more, or why it is that we have to drive a little further. But this is one of the big reasons, and just knowing about it and being able to, talk, mention this to legislators, right? Tell them that, people know about this. We are paying attention. I think that's one of the big things. And I think there's a really interesting sort of coalition to be made here, that there are so many big sort of important organizations that are against these laws, and there tends to just be one big organization for them, which is usually the State Hospital Association. But the American Medical Association has been against them, although they haven't made it as big an issue as I would like. Ask just about any economist, and they'll be against these as just a naked, sort of power grab restriction on money grab restriction on competition. The big antitrust agencies, like I believe Jordan mentioned, so the Federal Trade Commission and the Department of Justice, some of their biggest jobs is to promote competition. And these sorts of restrictions on new practices and the sort of things, especially that incumbent hospitals would do to try to prevent new competitors. This is all the sort of stuff that would normally be illegal, right? That the FTC and DOJ would be taking people to court for. The only issue is when a state government does it, like so many other things, when they do it, it's not illegal, right? And so what the FTC and the DOJ have to just do is write papers saying, "Hey, we think this is a bad idea. It's raising costs for consumers, and please repeal it." That's all they can do. But there are just so many groups like that. So you've got ordinary people who are having to spend more because of this. You've got the AMA being against it, I think, because it's preventing doctors from being able to easily expand their practice and shift more care to outpatient out of hospitals.
Dr. Bailey, you just used an interesting word, and I think it's so appropriate, and that is coalition. And Troy, I know that at the top here, when we began our conversation, you were talking about how your organization, Blue Cross Blue Shield of North Carolina, really has been rethinking how you're looking at certificate of need laws. And now it does seem that, even just as evidenced here today with our panel, a coalition of folks who are all trying to work towards the same thing, and that is to provide quality, affordable, accessible care to every North Carolinian. And I know that that's your mission. What's your next step when it comes to trying to move forward on this?
Blue Cross's next step, I think we are available to provide information and support to analysis of the issues. I think certainly for the lower cost sites of care, alternatives to hospitals like dialysis centers, like ambulatory surgical centers, home health agencies, I think we're ready to support an immediate repeal of certificate of need laws.
Jordan, I know that's music to your ears.
Yeah, absolutely. And, it just, again, it comes back to it. The reason that the Locke Foundation, works on these policies is because we really do believe them still being in place hurts patients, raises costs, erodes wages, makes it harder to provide health care. And that's the reason why we, work so hard, because we believe that it's holding back North Carolinians. And so I hope that the General Assembly and, members that are listening on this call, understand the urgency of this problem, and that, we can come together as a state and really reform a bad law that has a lot of unintended consequences to make healthcare more affordable.
This has been just such a great discussion. I can't thank you all enough. Dr. James Bailey, Troy Page, Jordan Roberts, and Dr. Bruce Schroeder. Really appreciate your perspectives on all of this. It's something we deal with, every single one of us, every month. If you're paying that medical bill, or you look at your insurance premium and you wonder, why can't my costs come down? Why can't I have an easier time getting access to that doctor or that specialty care that I need? That's what certificate of need law is all about in North Carolina. And that's why we at the Locke Foundation are urging lawmakers to get informed through forums like this and to understand the benefits of repealing certificate of need in North Carolina. Now, if you'd like more information, again, in the comment section of our Facebook page, you will find this new study written by Dr. Bailey, published by the Locke Foundation. Gives you great background and specifics as to his research on the negative impact of certificate of need laws on substance abuse treatment facilities, on mental health treatment as well, access to those critical areas of healthcare that people really need, particularly right now as we're going through this pandemic. I want to thank everyone for joining us today, and I hope that you will share this information with your friends, with your neighbors, because it really does affect every single one of us. Lastly, I would ask you to consider this. If you like the information that you are receiving during these virtual Shaftesbury Society forums, if you are involved in the public policy making process, if you understand the importance of what we're trying to do here at the Locke Foundation to make sure that people have access to care, it's one of our top priorities. We would ask you to consider a tax-deductible donation to help fuel the work that we're doing. Really simple. Go to johnlocke.org. In the upper right-hand corner, there is the Donate tab. Just click on that. It takes you less than 2 minutes to make a secure, tax-deductible donation to the John Locke Foundation. We will be most appreciative of that. On behalf of the entire team here at the Locke Foundation and at Carolina Journal, thank you for joining us. We'll see you next Monday for another edition of Shaftesbury Society. I'm Donna Martinez. Have a great week, everybody.